Percentage of patients or treatment sessions, would you say? Because probably 100% of patients. Treatment, yeah, it's up there, upper 90s.
Yeah.
But it's not a lot of people think of, I'm going to do joint mobilization. Joint mobilization could take 30 seconds to free up a restriction sometimes, right? Like if it's something that you've worked on before, it's not something you have to spend your entire half an hour, 45-minute session on. So it's
and if you are, then you're missing out the re-education component that's so important to physical therapy. So to keep it simple, if it's not moving, find a way to make it move, and then tap into their nervous system and find a way to get their body to continue to do that motion without your help.
So you touched on a good point right there. So say you do a joint mobilization, right, and you gain 10 more degrees into shoulder external rotation, let's say, right?
Sure.
Say you're a baseball pitcher for trying to get more external rotation, and now we've gained 10 degrees there. If we stop there, we're missing the big picture, right?
We're just doing chiropractics.
So what do you have to do then to re-educate that muscle, or how do you kind of keep that motion that you just gained?
Teach them to move it. So obviously the principles we use of PNF, of getting their nervous system to connect with their musculoskeletal system better so that they can stabilize into that new range of motion. Now, can they move concentrically into that new range of motion? Can they move eccentrically into that? Can they move isotonically in that? So it's just getting different types of contractions and using repetition. Obviously, repetition is how we learn to do things and learn to do them more efficiently. So you want them to be able to do every type of contraction that they could potentially run into out there in the world that would limit them from getting into that external rotation, like you said. But yeah, if you don't use it, you lose it. So they have to be able to use the contraction.
Yeah. So we work with PT students all the time in the clinic. And I think a big thing to note is a lot of them like to come in a little bit early and kind of write down, things on a notepad. I'm going to do A to P joint mobilization. I'm going to free up soft tissue. They kind of have a set plan of what they're going to do. But I would say for any PT student out there, just think about, if you're going for motion, free it up with that soft tissue or joint, and then just make sure you spend some time neuromuscularly re-educating that muscle.
We as a profession, we hold ourselves to very, very high esteem, and what we do is very helpful and important to people. But when it comes down to it, the going through the motions of doing the physical therapy is not a tremendously complex process. It's pretty simple and you can do it. It's understanding why and developing what you need to do that's takes a lot of learning and more difficult. But
yeah, for sure.
Yeah, treatment is not the most difficult thing in the world. We can make it simple. Make it move and keep it moving.
So what are the most common injuries or diagnoses that you treat that you use joint mobilization?
Yeah, so that's a really good question too. I would say when patients are coming into the clinic and they got their diagnosis, a lot of times we're looking, how does that diagnosis relate to that person and what does it limit in their life that they would like to do better? So very simply, functionally, what aren't they doing that we can do? So anyone who comes in with a mechanical restriction, we're going to do a type of joint mobilization with it. So this would be, all my patients, and they'll come in with a script for arthritis. They'll say knee OA, and I'll look at the knee and it'll look the feels that someone could have more pain and have more pronounced OA. Their radiograph could look much better, and yet their problem is knee OA. So what becomes the real problem there is, what is that knee OA stopping them from doing? So can't go up the stairs. So we're going to do joint mobilizations to get the knee into a better state where it can contract through a longer range of motion, get more receptors in their knee that produce some fluid that get things lubricating and moving again. So a circuitous route to answer that question is to not so much look at the diagnosis as the problem, but what does the diagnosis do that's stopping you from living your life? How can we help you with that?
Yeah, huge.
So the answer to the question, I could say a lot of people come in with a script that says arthritis.
And that goes right back to the point of, how often do you use joint mobilizations? Well, 99%, 100% of your patients, they're not all coming in with the same diagnosis.
Right.
So you're using it for just to help them be able to do something functionally.
We're trying to get them to the optimal state of function. We can't, a lot of people come in, another thing to say is like a lot of people come in with pain. Well, why does the pain exist? And can we put you in a state where you're less likely to experience pain? To say we're going to cure your pain, I think is a bold statement that I don't think is very accurate. If someone's telling you that, they're probably, they're not thinking about everything that's going on. But I can say, I'm going to put you into an optimal state of function, and that generally will reduce people's pain.
Yeah, that's good. All right, so talk about upper quarter screen and lower quarter screen and any specific ways that helped you learn them while in school.
No specific ways I learned them in school. You just got to know them all. And as you as you develop as a practitioner, you can sort of isolate in how many levels of screenings do you need to go with this patient. We could literally screen everything, and we'd be wasting some people's time because they don't need every component of that screen. But I would say it just takes practice and time to hone in what the most important things you're looking at in that patient. So your feedback on?
Well, yeah, I mean, I think as a student, it's simply memorization, right? Like you're memorizing it to try to pass a test. You're memorizing it to try to not have any automatic fails for safety issues when treating patients with your CI watching you, right?
Yeah. Don't miss red flags. That's the most important. Just don't let anybody die.
But I would say once you're an actual treating therapist with nobody watching you, do what you're doing, I think there's a lot of things that get missed. And I think it's important to know what you're doing with the upper quarter and lower quarter screens. So it's all about, to me, it's kind of like, why are you doing a reflex? Are you doing a reflex for the simple thing? Are you saying, well, they have a increased reflex, they're hyper-reflexive, so now I'm thinking, maybe an upper motor neuron issue, or am I thinking, they have no reflexes, so I'm thinking more lower motor neuron issues. But you can start lumping things together, right? Like if you have a increased reflex at the patella, let's say, and then your dermatomes and your myotomes, you can start lumping in kind of diagnosis and then where to actually treat from it.
I think that's well put.
So I think it's important to know that it's a screen in terms of making sure that there's no major red flag issues, which you should definitely do on every evaluation. But you should be doing a lot of these parts of the screen to figure out your diagnosis and to actually come up with treatment plans and what to do with them.
I agree. Very well put. When we're doing it, make sure what's the reason we're doing this. How are we using this to help someone? I think that's a good way to look at it.
Yes, I think a lot of people think of upper quarter screens and lower quarter screens as, should I refer this patient out? That's not generally speaking.
Right. Yeah. So that is an important component of it. Yes. Yeah. But you're using it to help form your diagnosis and how you can help that person.
All right, here we go. Favorite class in PT school. We talked about this one before before we're doing this. Mm-hmm. We both struggled with this one.
Yeah, I guess because it's kind of boring. It's probably just basic anatomy. I'm a very visual person, so cadaver lab, very helpful for me to understand sort of how the human body moves.
It makes sense with you talk about serial killers a lot of times. I could see lichen being in a cadaver.
It's a little Dexter maybe.
Yeah.
You got one?
Not really.
Post school though.
Post school, I think it's also tough. Like in school, I think it's hard to enjoy the material because you're so stressed out about passing a test and all this. Once you get out of school, you start taking CEUs. It's fun because a lot of times there's no post-test. You're in there for the sake of learning, and a lot of times your company is paying for it. My favorite class was PNF. Was actually the first course I took outside of. Well, technically, I took it while I was in school, but I've taken it twice.
Yeah.
But it's just a great course in terms of, people think of it as your D1, D2 flexion extension patterns. There's so much more that goes into PNF, proprioceptive neuromuscular facilitation that.
I think what gets really excited about PNF for me is it really is it is a staple of physical therapy that not a lot of other healthcare practitioners do. Like, I mean, joint mobilizations. There's a ton of different osteopaths, chiropractors, a lot of fields that do this, but I don't really know any other fields that really hold on to PNF like PTs do. So I think that it helps individualize us. I think it makes us stand out. Why should I come to see you over this other profession? And I would say a major part of that is we're going to re-educate your system.
For sure. Now, as a whole, let's go on a little tangent. Do you think that physical therapists as a whole are good at this concept of NMR, neuromuscular re-education, PNF strategies, or do you think that we tend to fall into, I'm kind of biasing your answer right now by me asking this question, but do you think we tend to fall into more of, hey, there's a mechanical restriction, let me mobilize your joint, let me do some exercises? Do you think we miss the picture? You think we do a pretty good job of re-educating things?
Everyone falls into their different patterns and how they do things. I think the people I know do a pretty good job at it. But yeah, PNF is hard. It's harder to do than it is to do a mobilization and give someone exercises. So when things are hard to do, I think some people don't. To do PNF well, it's going to take years of practice, and you're not going to be good at it first, and you might have some bad results early on, which can bias you away from doing it. I'd say if we fall away from it, it's just discipline time. Do people want to put a lot of effort into this? But I think it's probably the most important skill. If you want to ask me about how many patients do I do PNF on, that would be 100 of them. That would be the one other patient too who wasn't getting the mechanical treatment, still needs to get some level of tissue re-education, or I don't know why you're coming in my door.
Yeah. So when I was a student, PT student, my last rotation, it was like a month or two before I'm actually going to graduate. And my CI, Tom Swinson, great guy, he had this PNF slot. He was taking the class. He's taking it for like the second or third time. And he noticed that I started to have an interest in, actually, another physical therapist that was working at our clinic was doing all this PNF and doing some of these techniques I've never seen before. And he noticed, and he had no ego. He said, why don't you go over there and watch her a little bit, see if you can learn anything. I came back to him like a couple hours later. He said, what do you think? I said, that was incredible. Like, I really want to learn some of that stuff. And he said, well, I'll tell you what, I've got this class, the PNF slot I'm already taken. He's like, I'm going to retire soon. Why don't you take it?
That's awesome.
So he gave me this spot for free. So I'm going as a student, which was terrifying because it's all physical therapists in there.
Right.
Most of who, I'm still trying to figure out my hands and figure out what to do. And they're all kind of much experienced, people, just normal people taking the class. And so that's where I found I ended up in a residency through this thing. But I remember talking to my residency mentor after taking the PNF class. And I went in there for, I think, my interview. And everybody, there were maybe 6 or 7 therapists, and they all had people on the table all doing some sort of PNF pelvic pattern that I had just learned in the class. So I talked to him. I said, man, that's crazy. Everybody here does the same pelvic patterns. It's like that. I don't know. It seems weird. And he said, yeah, but why do you think they're doing it? And I said, I'm assuming, and I thought about it. It's like, I really don't know. And he's like, yeah, you could have 7 different patients on the table all getting the same pelvic pattern or PNF pattern, but all doing it for very different reasons. And it was kind of a cool concept of like, people think that these patterns or, these different movements, it's like a one size fits all, but there's so many different variations of PNF. And, now you can break down, it doesn't have to be your whole arm. You can break down just the wrist. You can do it with carpal tunnel patients. You can do it with nerve patients. You can do it with anybody. And it's so cool to think of like,
it's our basic human reflexes. It's how we developed motor control in utero. It's based off how we developed and how our nervous system and musculoskeletal system talk together. So yeah, that's true. We can do it on anything that moves.
But do you think as a PT student though, that makes it kind of scary? It's like there's no one set answer.
Yeah, but I think you got to pay it forward now. I mean, think about how different your life is because he did that one thing for you. I think you probably got to pay for a Mary Baldwin student to go to a PNF course at some point.
Yeah, budget's a little tight right now.
Yeah.
But no, I think that everybody likes to have one set answer. Hey, here's what you do if you get a patient with neck pain. Do these 3 mobs and you're good to go.
Yeah, it doesn't work.
It doesn't work, unfortunately. But it works on a test. So if you have a test, you could probably map out these 3 mobilizations that you need to do and you're good to go.
Yes. Good answer.
Let's see. We got a question here from Spencer. Welcome, Spencer.
Sure.
So he says, how long did you do a residency and why did you choose it? So you didn't do a residency, but I think you can talk about
we can talk about
the
positives to both sides of it. The most important thing I tell students is to get around other good PTs. So I didn't do a residency. I kind of cheated and did one. I really did do one. It was not as a formal residency as you did. Mine was with Corey Silbert, a PT who was a CFMT in New York City, and she took me under and was able to. I worked for Corey for about 2 years. I would say that was my residency. But you did do a residency. You did a formal residency.
I did. One of the coolest things. So I just knew, just to answer your question, the residency was 2.5 years long. And then why did I choose to do it? So I took this course, and that's the first time I met my residency mentor. But actually, so he was a great instructor, great everything. Couldn't be happier with the residency. But it was actually the lab assistant. So the lab assistant, Sam Fierro, for anybody that's watching knows her. So Sam Fierro was a lab assistant. She was a resident about to finish up her residency. Mm-hmm. And so she's studying for this test that you've taken and successfully completed. Mm-hmm. Very stringent test. It's a week-long process of hands-on and didactic, all this stuff. And watching her excitement for the material and watching how good she was.
Yeah, it's exciting.
Really excited
to see somebody really treat that's doing it.
Because she's like maybe 4 or 5 years more experience than I am. But watching her respond to my residency mentor was incredible. And then watching their interactions was saying, like, I know this guy is super smart. I need to learn as much as I can from him.
To want to have that drive to work hard, to be like one of your mentors. That's what's exciting. And I think what drew me to these, these groups of people who were doing higher level therapy was I just loved seeing the patients get off the table and be better. I've worked in clinics where like, and I'm not knocking any specific PTs, but when I hear like, just trust me, the research says to do this. If you do this for 2 months, you're going to feel better. And they didn't change anything on that day. I just love the seeing a great clinician take you from, well, I'm going to test your range of motion now. We're going to make it 20 more degrees. You do that, you stabilize it, and the patient's like, holy crap, that's 20 more degrees. All right, great. See you next week. Like it's just exciting to feel validated to make changes for people.
Yeah. I think I was the only one from my PT class to go into residency. I could be wrong on that, but from the friends that I kept in contact with. And I remember talking to them and they said, well, aren't you going to make less money? And I said, probably. And they said, well, I've got one person even got a director position right out of school. And I thought to myself, I even asked him, I was like, you feel like you're ready for that? Like, I feel like I don't know anything right now. I've got my license, but I don't know anything.
I don't think that probably didn't go well. I don't know. But yeah, there's tons of residency programs out there. I always tell students, get around some people, and when you see someone who you want to be like, do a residency with them. Will did his through the Institute of Physical Art. Yeah. There's NIUMP is another great some people really like the Stanley Paris approach. There's a million residencies you go to. You want to be around someone you want to be like, and let them show you the ropes.
Different personality types too. For me, I need structure. I need to know that, hey, there's a 2.5 year program, and here's what we're going to go through. We're going to go through this class, then we're going to do journals, then we're going to do one-on-one time. There's going to be this exam. Like for me, that really helps, and it keeps you focused. Other people are very self-motivated and self-taught and can go through all the courses on their own and completely be fine. Yeah. So it's really whatever you want, whatever you can handle.
Beautiful. Good advice. Any other last questions?
Yeah. Last one is, any important tips when performing joint mobilizations, like best way to get a feel for it and understand it?
It's easy answer. Practice on your girlfriend, practice on your mom, practice on your dad, practice on your friends. Just touch people. Get used to feeling tissue and touching. Treat yourself.
Make sure you don't go out in public.
Yeah, let's get consent and then touch people. And treat yourself. Like I'm always like, you'll see me anytime I'm feeling something. I'm digging in my AC joint a little bit.
We'll talk about, so you're a PT student, obviously not now, but way back, right?
Mm-hmm.
How did you ever have these like aha moments, or was it just like over time you just started to know what you're feeling? Were you ever unsure of what you're feeling? You're just trying to hopefully figure it out one day. What were some of your past experiences?
Yeah, you definitely have. I think you have to show a level of confidence for people to accept your hands into their tissues and things like that. So you can fake it to make it a little bit if you're not sure that you're exactly on the fibular nerve. If you're treating tissue around the fibular nerve that's freeing up the fibular nerve, you can say, well, we're freeing up the tissue around your fibular nerve. So have a level of confidence and just get comfortable with your hands.
There was so I mentioned Tom Swinson in my last rotation with him. He was like, I don't know, 60, 62 years old. He was on his way out. He knew it. But he knew a little bit of everything, which was so cool. And I remember we were doing an eval, and I was leading it, and it was a lower back patient. And we were looking at posture, and the guy had his shirt off, and we're looking at the height of the pelvic crest, and we're looking at the height of the retrotrochoners, and then we're looking at PSIS and seeing is there a rotation, is it elevated, is it not? Remember, so first he said, all right, check to see the level of PSIS. So I check the level, and I say, one is way lower than the other. And he says, keep your hands right there. He gets on, he says, well, you're on the body of this one on your left, and you're at the superior aspect of the one on the right. So he said, that's not going to work. I said, all right, so take your hands off, and he gave me a strategy for, all right, now we're always going to be at the top of them, right? So you're always the same thing. But I remember there was this moment where he said that there was a rotation. He said, feel the PSIs. Can you feel that the right one is deeper than the left one? And I said, I felt it for a while, and I said, to be honest, I don't. And I remember having like this huge amount of discouragement as a student and saying like, I can't even feel, like this seems so basic to me. How can I not feel it? And I remember Tom Swinson said, don't worry about it. You'll get it. He said, just keep trying. He said, I'm not concerned. He's like, if you're concerned, let me know. But I've been around so many students, I'm not concerned at all.
Yeah, I've definitely had the exact. I can't think of the example.
We all go through those, you know? So as a student, I think when you go and you try to feel this stuff and you don't feel it, I mean, there's a big thing about the power of intent. So that's where you're saying PT's hard. So if you're a student, you say, I can't feel this rotation, so now you never check it again, and now you're missing out a huge treatment component because it's too hard. Yeah. And I just need to do core. You're missing, like you're limiting your opportunity to be great. I think that's where
push,
you need to
push yourself on your weaknesses to work the hardest there.
Yeah.
Don't just stay in your strengths.
And a student is a perfect time because you're not supposed to be an expert at anything. You're supposed to suck, to be honest. So take the opportunity.
I usually, in encouraging people to go to residency programs and doing continuing education, I usually say that PT school kind of teaches you to not kill your patient, and then after PT school, it's on you to get good at actually making them better.
Still not kill them. But yeah, no, this is a great topic. So, I don't know how much it'll help with the test next week, but hopefully it gives some more clarity about what real PTs out in the world are doing and using it for. And we love the question. We got a comment from Dai Kwang. He says, great sentiment. Treatment is supposed to be individualized. Patients have a better buy-in when you see them as an individual as opposed to being a mold. So this is Q. He's a PT that we work with. Yeah, Q is amazing. He's right on with that.
I would 100% agree with him on that. That makes perfect sense. It shows when you care.
Yeah. So we're kind of working with Mary Baldwin physical therapy program. Did a presentation. I think some Shenandoah students are going to come out. Doing a presentation for GW students next Wednesday. I'll be talking about neuropathic pain in the upper extremities. But any questions that PT students have, PTs, sports-related questions, we're still open for that.
Yep.
Patients, whatever. We're willing to talk about
100%. We're here to talk.
And go on it. So unless there's any more questions, I think we're going to call it a night.
Over and out.
Over and out.
Pretty good.